when you.
Oh, looks like it's.
Hi, everybody. My name is Catherine Forneely. I'm an assistant professor at the University of Maryland School of Nursing, and also have been on the editorial board of the Journal of Addictions Nursing for many years now. I'm the editor of the Policy Watch column. So I'm an associate editor. And I regret that Dr. Lynn Schell is not available to lead the journal club meeting this week, this month. But I'm trying to fill her shoes, and we miss her and hope she'll be back soon. So today is July 14th. It's 12, our meeting started at 12:05, and we're going to be reviewing the Journal Club article for this month, which is a feasibility study to direct system level change for hospital patients with alcohol use disorder. So I'm very pleased to introduce Dr. Amber Golden, DNP, APRN, AGP, CNP board certified. And she's also representing her co-author, Dr. Lynn Buchanan. So Amber, welcome for being here today. And thank you for agreeing to discuss your paper with us, which was published in volume 32, number 2 in 2021. Welcome also to Dr. Tara Mariolas, who teaches nursing in Massachusetts, and Mr. John Silvani, who is a current INSA board member and also was on the board during my presidency of INSA, which ended the 2-year period ending October 2020. So hit it, Amber.
Okay. Hi, everyone. Thank you as well for allowing me to come be a part of this discussion. I look forward to speaking with you guys. So a little bit about me. I work as an assistant professor at the University of Nebraska Medical Center in Omaha, Nebraska. I teach a slew of nursing courses in the undergraduate and the graduate level. As Catherine, Dr. Fornelli had said earlier, my specialty is in adult gero primary care. And so in the graduate level, I teach that graduate program. I'm also a nurse practitioner. I work at a student health clinic 1 day a week. So, yeah.
Thank you. So your study, the feasibility study regarding system level changes for hospital patients with alcohol use disorder, what led your team to implement this practice change?
So at the time when the project began, I was a graduate student. This topic was, along with a list of other topics, was presented to us. At the time, we felt that this population and this topic was the biggest concern at the time for our local hospital. During the very initial process, when we met with the stakeholders, we had found out that the alcohol use disorder patients were being readmitted at a high rate, and we were trying to figure out what is the fall point of like what's missing. And then we started realizing that it was the discharge process that was lacking. We had realized that the patients didn't have a standardized discharge process. And so that is where we came up with the intervention in order to create a system level change and standardize the discharge process.
So could you talk to us first about the purpose of the study and the different measures that you use to evaluate the pre and post measures for your study, and maybe who implemented it and how it was implemented during the hospital stay?
Yeah. Um, so the main purpose of this study was we wanted to make a practice change. In other words, and as I stated in the article, a system level change.
Mhm.
Um, and we also wanted to standardize the discharge process with this population in particular.
So being a feasibility study, um, does this mean that you're now going to implement a larger study, or was this to ensure that the processes worked for the staff so that they could implement a practice change as opposed to research?
Yes. So yeah, our big goal was was for research, but also we really wanted to make a change for the staff. So for not only just for the nurses, but we really wanted to make a practice change for the whole interprofessional team. So that includes the social workers, the pharmacists, the providers on each of the patient's team. We wanted to be able to make the process a little smoother and as stated in the article, to help with that interprofessional communication, to help maybe bridge that gap in some barriers in communication.
So looking at your purpose statement, you were making this system change and standardizing the discharge protocol to include a session with each alcohol using patient that was identified by the nurses on the unit or the physicians, and then provide some kind of a brief intervention that was motivational enhancement based, motivational interviewing based. And you provided tailored discharge education material and made a place in the electronic medical record for the different professionals to record, or at least to be able to see what had been provided to the patient.
Correct.
So I think I read that you had, there were three nurse investigators, right? Who were they? Were they
Yeah.
staff nurses or?
No, so the two other investigators were two other graduate students,
Mhm.
Chelsea and Nicole. Um, they, at the time when we were given our scholarly project, we were placed into groups.
And so I read in your study, or you could explain the process of how these nurse investigators made it to the unit. I think you called every morning to see if there were people with alcohol problems that they could go visit.
Yeah, so what we did is each day we called up to the whoever was the nurse manager at the time or the lead nurse at the time to find out which patients had been admitted with alcohol use disorder. The nurses knew based on like the admitting diagnosis. And so once they told us, we also found out if they were nearing their discharge because we didn't want to visit them any earlier. We wanted it to be within 24 hours of their discharge.
Mhm.
And so that's how we were able to pick. And a lot of times when we would call, we would also find out from the nurse um, about like if the patient was willing to be in the research study, and if it was a good day for the patient, or there were quite a few times when it might be just too early in their hospital stay and they just were not either coherent or not ready to be um,
So you or one of your two graduate student partners would then go over and ask the questions on the motivational interviewing script, which you provided on page 98 and 99 of the manuscript.
correct. And so yeah, the three of us, we had our individual roles. The one per Chelsea, her role was to go in, get consent from the patients and collect demographic data. And then my role was the motivational interviewing script. And then the other investigator, Nicole, she was in charge of, we had done a 14-day follow-up phone call.
You did do a follow-up protocols. So how many of the patients that you all saw in the hospital were able to be followed up after discharge?
What was that? That investigator had focused on those results. At the time, we I don't believe it was all of the 14 participants that we were able to get a hold of via phone. I don't remember the number. I have it somewhere, but my focus was on the motivational interviewing and the pre-readiness and confidence, pre and post readiness and confidence scores.
So that brings me to the script that you used.
Yeah.
Yep. And do you want to describe for our audience who might not have the article in front of them what the different parts of the script were and how they were sequenced?
Yeah. So we did, with this being my focus, I did a lot of research in my literature review at finding out about motivational interviewing, trying to look through different scripts. They're based on evidence-based practice. These were the questions that were asked in most motivational interviews. And the big thing with ours is to kind of back it up. As you see in the questions, we want to find out about the pre and post readiness and confidence scores. The way we came up with that was the trans-theoretical model. I won't bore you guys with details, but
I mean, the people that will be listening to your article summary at this particular journal club, they're already interested in motivational interviewing and other issues around substance use. So please feel free to explain to us your protocol and how you did that.
okay. So yeah, the way that we came up with one to tie in about finding the readiness and confidence was research had shown that with using the trans-theoretical model, they looked at self-efficacy. And in our in researching a lot of stuff, we had found out from previous research studies that they had assessed their self-efficacy, the patient's self-efficacy, with readiness and confidence rulers. And so to make it a measurable study, in this case, this is where I wanted to turn to show, to ask those questions. And so with this motivational interviewing, we asked in the beginning, how confident or how ready do you feel that you want to make a change? And so that's how we began this motivational interviewing. And then once we found out those answers, we moved down the line with the questions. And it was really an interesting study to hear the variety of answers that we had gotten. And it really was, there was quite a variety, whether, depending on which question it was. But what I was really shocked about, not shocked, but really in a good surprise way, I was happy that the patients were willing to answer each of the questions.
You bring up an important part about why nurses need to know addictions and why addictions nursing is so important, because nurses have been the most trusted profession every year for about 21 years or so, except for 9/11. And during that year, first responders beat us by 1 point. And other than that, we have a long a long history of being the most trusted profession. So I think some patients wish that somebody would talk to them in a non-judgmental way about their substance use.
Yes.
Yeah.
Yes. And so, and I think that these patients, with me, I was able to see each of the patients and do the motivational interviewing with all of the participants.
Mhm.
And it was, it would just was a really, it was a good study just to be able to, for them to be able to just talk and open up.
So the first question is, do you want to quit drinking? And if they did, then you would ask them how important it was and how confident they felt. But one of the questions I had was, how did the nurses identify patients to refer to your team in the first place? Like, how did you know who needed the intervention or could benefit from the intervention?
Yeah, so the way that we decided this was we chose, there was a list of ICD-10 codes
Mhm,
that involved the alcohol use disorder diagnosis.
mhm,
And so we gave the nurses um, that list because at our local medical center, when a patient gets admitted, they're admitted with a specific diagnosis and a diagnosis code.
mhm,
And so the nurses were able to look through their list. And to back up, we were on 2 medical surgical floors. And so the lead nurse had access to look at the whole list of patients. And so she was able to look through the list and see, based on the admission diagnosis or the admission diagnosis code, just in general of which patients. We didn't go any further in depth as far as like asking the nurses, how ready do you feel? Like, do you feel like they'd be a good patient? We just, that was kind of our,
So you were trying to universally screen all of the people that were identified on the list as having an ICD code.
yes,
Okay.
that is correct. Thank you. To put it in correct words, yes.
And so part of, I'm real thrilled to know that you were successful at that, because I don't know if you know that my DMP project was on implementing SBIRT in an ambulatory care clinic at the University of Maryland Health Systems, which used the same electronic medical record that the hospitals used. But we found, or I found in my project, that most of the patients didn't have an ICD-9 code that we could retrieve.
Oh,
Sometimes it, the first code on the list would be heart disease or diabetes, and the substance use didn't come down until after maybe the 10th diagnosis and were not retrievable easily. And the
wow.
physicians were not always assigning a diagnosis to patients with alcohol or drug use disorders because of a number of reasons. One is, when you're a hammer, everything looks like a nail. So if you're a nephrologist, you're looking for nephrology diagnoses.
Right.
And also because a lot of our patients um, had to, a lot of people who use substances don't have paid sick leave. And so they have to be absent from their jobs in order to go to a clinic, or even they have to provide a discharge, some kind of note from the doctor to confirm that they were in the hospital. And patients in our setting anyway, I don't know how it is in Nebraska, are often hesitant to allow a physician to put a substance use diagnosis on their discharge summary sheet, because they don't want to send that sheet to their employer. And, which leads into a bunch of other questions that, I've been teaching SBIRT since the year 2000, but I didn't implement an SBIRT project myself until 2016, because I'm one of these older nursing students who didn't go back to get a doctoral degree until I was in my 50s. So um, I I know that an important component about implementing a substance screening project like yours is that this hospital needs to make sure they maintain substance use information separately under 42 CFR Part 2, which is like HIPAA for substance use disorders on steroids. And so there's criminal penalties that can be made if you release information about someone's participation in treatment. And the barrier to accessing treatment is patients being afraid that their information may be revealed to others. So I'm understanding that your project is a preliminary project designed to work out some of the details before you fully implement the practice change. And I think your hospital might want to look at that because they're going to be considered a federal entity because they receive Medicaid or Medicare, which, you know, is federal money. But that's why we had a hard time identifying, even by reviewing progress notes, the place on the chart in the EHR where the physicians wrote alcohol, yes or no, other drugs, yes or no, was most often left blank. Even when the patient's record progress notes said that they were having endocarditis from intravenous drug use and abscesses and hepatitis and HIV from drug use, they still, our electronic health record, we could not query that information. So I'm pleased that you were able to do that. Did you find much change in your readiness and confidence scores from beginning to end? Because you started with the pre-test readiness score and the post-test readiness score, and then you delivered your brief intervention that used motivational principles. And then before you closed the interview with the patient, you did the score again. Were you able to show much movement of the needle from the pre and post on the confidence and readiness scores?
Their pre-readiness and confidence scores were already really high to begin with. The average was in the 8 range. And so the post scores really didn't change much from the pre scores. They did stay high and they didn't go down, which was good to see. But no, there was minimal change from the pre to the post. But yeah.
And you told me in one of our phone calls that one of your student partners in the graduate program also evaluated these patients 14 days after discharge. Did you find any, you know, information about how your results compared to the other students' results after discharge?
Yeah, so when she had done the 14-day follow-up phone call, we were just finding out mainly qualitative information of like, did they start drinking again? Were they able to do a couple of the interventions or were they successful in the couple of the goals that we had created during the initial interview?
So did they stop after your interview, and did they stay stopped, or did they return to drinking?
There were a couple that most of them actually did stop, which was really a good sign. I think there were also a couple that switched maybe from like hard liquor to beer, or they cut down the number of drinks.
That's a really important thing to measure.
Right, yes.
Did many of them go to AA? Like one of your interventions was to refer them to AA. Did they do that?
I don't think any of them had gone to AA within that 14-day period of time. But they definitely, they had said, I'm planning on going to AA. And when I had done my initial MI interview, we had discussed and shown like our local hospital's AA group, as well as we tried to find some AA groups that were nearby where they lived or within their vicinity.
So knowing that AA is an adjunct to treatment, but not treatment itself, and that people with high problem severity might benefit from treatment, but people with lower problem severity that are able to meet and, to set reasonable goals and try to attain them. But people with dependence in particular, they might be the people who absolutely could benefit more from treatment than just a brief intervention by itself. Were you able to refer any of these patients to, well, first of all, how many of them were high severity need? Or do you have an estimate maybe? And did that correlate to readiness to change at all? And was treatment indicated for some of them?
Yes. So all of these patients, they were admitted due to whether a couple of them may have admitted themselves to the hospital, or they were in having severe alcohol withdrawal symptoms or such and such. And so we didn't necessarily measure their severity of like their alcohol detox symptoms and withdrawal symptoms, but we did measure their what it said, their readiness to change. And
But did you
so
correlate any of that with their diagnosis codes? Because some of the diagnosis codes were just they were intoxicated, but some of the codes were alcohol dependence with withdrawal complicated, So did you notice any differences in your patient population, which was kind of a small n because it's a feasibility study, and you're really getting the nurses on the unit to have a higher level of awareness about how to intervene with these patients? Did you notice anything in terms of people with withdrawal being more interesting in quitting or less interesting in quitting?
yes. So I would say, we didn't necessarily, I don't know how to put this, but I would say the ones that were in a pretty severe state, you could tell there were the ones that were not interested in making a change. And so maybe some of them had the low readiness and confidence scores, but then the ones looking back, I would say the ones even the ones with high severity, there were a few that still were one to make a change, definitely. But then I would say there were more maybe with low severity one to make a change.
I think maybe people with low problem severity feel confident in their ability to change more than people that know that they're going to go into withdrawal if they don't get another drink, and knowing that they have the dependence diagnosis and what withdrawal feels like might make them feel less confident. I think if as you move forward with this at your hospital, I think it's going to be important to distinguish the practice change that the nurses on the units are delivering, and then you as a researcher could measure more once you get a bigger N, with more patients. I think it would be important to kind of try to correlate whether there were differences between those with the more severe alcohol use disorder and their need for treatment, as opposed to somebody with a more with a less severe substance use disorder who can feel confident that they can change their drinking behaviors on their own.
I agree.
Is there an addictionologist at your hospital?
No, a lot of the providers that had admitted these patients were the hospitalists or the internal medicine hospitalists.
And you provided results back to them probably before you shared this with the Journal of Addictions Nursing.
For sure. Yeah. And so we had a really close relationship with our stakeholders. We met with them on a frequent basis.
Mhm.
And when we had finished the study, we were actually able to present the study to them and the results and what all turned out. It was a really good. Yeah.
So are they going to take over the role of screening and assessing patients after, I mean, you guys graduated, and now who's doing this now that you're gone?
You know, I don't know if they have taken the step forward um to continue this process to implement the motivational interviewing within the discharge and the tailored education as well as the EMR flow sheet. Um, I know that they talked about possibly continuing to do it, but I do not know if they had continued it after us. But they, I mean, during our some of our final meetings, they thought that this would be a great change for the hospital system, and that it it changes always, as we all know, nurses. We our shifts, the working shifts are very busy, and so sometimes it's hard to make a change to add on something to the discharge process. But depending on, not depending, but like how we would present it to the nursing staff for the medical surgical floors, well, any of the floors, um, of how they could implement this into their discharge process. And so that would have been like the next step we would have taken to try to get them to continue it.
So what are your plans for the next phase of this project?
I um I thought about possibly just reaching back out to the stakeholders to see um, maybe what the readmission rates are at, to see if they've noticed any differences in their population, and to find a way that I could help them to make the system level change.
Mhm. So they're generally in favor of it and are glad you did it.
For sure. Yeah. We had gotten really positive feedback from the providers as well as the nursing staff. And
How did
then
the patients feel about it?
the patients were actually very excited about this. A lot of them were like, especially like with the tailored education sheet, they were like, I've never been, given this information. I'm actually really happy that you took the time to teach me this.
Mhm.
And they were actually happy with the motivational interviewing, because they just said, it was just a time for me to be able to speak however I want to someone who's a complete stranger, and I don't have to worry about being judged. So the patients themselves really loved this.
I think maybe what patients and staff appreciate is that you're integrating discussions about alcohol use into the overall care that they receive for whatever care they're seeking. People may be not sure about whether they want to enter treatment, but they know they want to get their gallbladder or their pancreas or their diabetic foot or whatever brought them to the hospital dealt with. And I think a take-home message for staff that are not in the addiction specialty full-time is the importance of integrating questioning about alcohol and drug use in a non-judgmental way, which it sounds like your study did, because you all based it on the trans-theoretical model of change. And that's a big take-home message. Now, I don't want to be the only one talking to you, and we've got like 20 minutes left. So I'd like to, Jacqueline, I don't know which Jacqueline you are, and Kelly Kokas logged on after we had started our recording where we introduced ourselves to each other, but to make it be an interactive experience, could each of you that are on the call today go open up your chat box real quick on the Zoom and make sure it's directed to everybody, not just to me. And because you can direct it to everyone or any one person. And can you very quickly, just off the top of your head, put 1 or 2 words that that this discussion stimulated you to think about alcohol screening. And you can say more than one thing, but try to keep it with 1 or 2 words for each thing, or each concept that you're thinking about, or each reaction that you had, and divide them by a comma. So if you have 3 things, you would go thing 1, comma, thing 2, comma, thing 3, comma. Think about it for a second, put some of your reactions in the chat box, but don't hit send until I say go, and everybody sends them all at one time, and we'll have a waterfall of feedback for Amber, and creation of some other discussion points that we can involve Kelly and Jacqueline and John and Tara, who have not, and Olaremi, who have not been speaking yet so far. So do people feel like they're almost ready? You could put your microphone on and say, okay, if you're ready, so that I don't tell you to hit send too soon. But we've probably hit most of you now. So I'm going to go 3, 2, 1, and then we'll hit them. 3, 2, 1, go. Okay. So Tara, you mentioned 3, is it Tara or Tara?
It's Tara, sorry.
Tara.
And I realize I sent my words to you privately, so I apologize. I'm not used to using Zoom much. I use Google Meet a lot.
Okay. I've been living the past 18 months on Zoom. So, so Tara, your words were experience, cognitive, and support. How did, very briefly, because I want to hit each of you, what are you thinking about experience, cognitive, and support in relation to Dr. Golden's manuscript?
Well, I was really impressed by her being struck by the lived experience that the questions elicited. And I think in my work with adolescents and adults, with my students, the most important discussions we've had is people talking about their lived experience. I think we've learned things that we just didn't know. And also I wanted to sort of explore more with Amber, to what extent did any cognitive changes that resulted from years of drinking affect the results in your mind? And once people left, did you think about what could be in place to continue the momentum that you perhaps started with these individuals?
Yeah, those are really good questions. With the cognitive status, we measured more of to see if they were able to read our education. We did a little measurement with that, just based on their education level and that. But we did not measure their cognitive. Well, no, I take that back. We did do an orientation during the initial interview process, just finding out, making sure that they were oriented to person, time, place. But
Good.
as far as the progressive cognitive status of how much alcohol has changed them, we did not go look into that, but that would be a really good area to focus on. And then what was the other question? I forgot.
Yeah, I just wondered, and maybe you addressed this in your paper. I apologize for not knowing it if you did. What in your mind, as you did this study, were you thinking about needed to be in place for these individuals, perhaps besides treatment or AA, that could, these people were optimistic, they were confident they could maintain the progress. Were you thinking about anything, or from your interviews, did you find anything that might need to be in place additionally to keep people's progress sustained?
Yeah. When we did this project, we really thought we wanted to make it easy enough, not easy, but manageable enough for the staff as well as the patients to not make it a burden on the nursing staff, as well as not
Mhm.
make it a burden on the patients. At the time, we cannot think of anything that's additional that we should add that would maybe make it more easy. But I think to keep the motivation going would just be for me to follow up with the nursing staff
Mhm.
on those two medical surgical floors. And also it would be good to expand the project to more floors within the hospital.
Well, I just wanted to add one comment. I'm really impressed at how well you collaborated with the nurses and how open they were. I mean, I'm trying to beat down a door right now to do a study. And you brought up some really interesting points, Catherine and yourself, about ICD codes and confidentiality. So, we're trying to do something where we might be able to develop a model to detect people at risk for overdose. And I'm pulling my hair out trying to get access to medical records. And I don't know if it'll ever happen, but I'm very impressed by the support your nurses provided for your work.
Thank you. Yeah, we had a great team of nurses on both the floors. They were so willing, and they always had a smile on their face and were always willing to talk to us. It was good. Yeah.
So thank you, Tara, for weighing in on this conversation. How about John Silvani, very quickly, because we only have 10 minutes left. Could you, I know, John, you work in opioid treatment in Ohio, where they also have a huge overdose rate and a huge need for improved access to opioid treatment. But your comment was that you're starting at your place. You said I think you mean your staff and you are thinking about alcohol patients. And so this was interesting to you. What makes alcohol interesting to somebody who mainly focuses on opioids?
Well, here's the thing. One of the doctors I write some policies for is very into taking care of alcohol use patients. So what he has a place, his name is Dr. Moss, and he wanted us to do some outpatients. We got about 7 to 10% of our patients that also have alcohol use disorder. And we're lucky we have 3 addiction specialists here. And the one that's actually that wants to bring these folks in, I found out that the motivational interviewing was good because Espert, we've been used in emergency rooms for a long time, and that catches them right away. But I was interested in, so you had these folks longer because they're on a med surg unit or whatever, and you could talk to them at different times, because we're always finding out that we use Camprol, we use a lot of different drugs to help them with their alcohol problems. And I have a psychiatric nurse practitioner that specializes in that also. So they want to bring them in. And I just looked at your thing and I said, this is exactly what I need to do. This is feasibility study, but it means that it's difficult because we're worried about, them not having enough staff to we have a nice ambulatory stabilization room that has but to take care of these people if they have issues going through, and we're not a med surg unit or we're not a medical detox unit, but we do want to help our patients that happen to be addicted to opioids and alcohol. So I thought that was great. You did a great job. Dr. Fornelli she's a great teacher. And every time I look at her, I think I'm back in school with my teacher. And, because she asks the greatest questions. And I have another nurse in the room with me who's one of my charge nurses here. And she was like, I said, you're going to get a treat here with Dr. Fornelli, because we do buprenorphine. We actually dispense. We're like a pharmacy. We became a pharmacist and a nurse because we administer and dispense buprenorphine. And then you can see I'm in a room where we do methadone. That's the windows and things like that. So we do methadone and that. But thank you so much, and I'll get off.
Thank you.
John, the reason why I wanted to hear what you had to say about alcohol is because, and I put a little link in the chat box. I don't know if this is exactly the right link, but Dr. Koob, the director of NIAAA, the National Institute of NIAAA, the National Institute of Alcohol Abuse and Alcoholism, they've been doing a lot of research there. And if you still have access to the INSA webinars on the last conference that we had in October, Dr. Aaron Smith also presented on this. Sorry, my dog is going nuts because the skateboarder went down the street, but they've got drug and alcohol broken out into two different silos. And a lot of us are looking at opioids, and then we're neglecting other things like alcohol and amphetamines. And the NIAAA, the National Institute on Alcohol Abuse and Alcoholism, they're like the alcohol version of NIDA. And they are starting to present more and more. Dr. Koob has probably some PowerPoints that you can find online that talk to you about the interaction between alcohol and its influence on the opioid overdose death rate and suicide rate. So yeah, I think it's great, John, that you guys are starting to think about alcohol. Now, Jacqueline, we didn't hear from you yet. Do you have a camera or a mic or do you want to say anything? And Kelly, do you want to be introduced? Hi, Jacqueline. Thanks.
Hello, everyone. I'm so pleased to be a part of this discussion. I want to thank Dr. Golden and you also, Dr. Fornell. I'm new to knowing you ladies. However, I've been in the field since 1970 or so, starting on pediatrics. I recognize addiction, the early signs of it in some of my little guys, my little patients. And also, of course, at that time, we had a lot of heroin addicted babies on withdrawal. I moved on from there to work in the field more permanently and was certified as an addictions nurse. I'm very pleased to see this because to me, it seemed like it was a forgotten area. It's only now blossoming into a field over the last 10 to 20 years. And I'm so pleased to see that because this has been my passion and my heart. I had a private practice for 14 years working with recovering alcoholics. And I agree with you that we have to focus on the alcoholism. When I was in the early years in the 70s, we talked about smoking and marijuana being gateway drugs to alcohol. And then, of course, then came the harder drugs, the heroin. And now, as you're saying, the more recent drugs out there on the street. And it all, including prescription drugs, is all inclusive. And I appreciate what everyone has had to say, everybody's input so far. I just wanted to say that when the patient comes into the hospital, if they don't catch it in the ED, it would be very important for once the patient's on the unit, the role of the nurse, Dr. Golden, is key in identifying someone who has a substance abuse addiction. Unfortunately, although the hospital I worked at was the premier hospital in addiction, Beth Israel, when the next hospital took over, Mount Sinai, it's almost become something in the back burner. And I worked as a case manager before my retirement in December. And I had to really fight for the addicted patient, no matter what the addiction was. They missed the signs and symptoms of addiction and were attributing it to medical, surgical issues. And if it came out that a person was addicted, then there was the stigma. I was so shocked that in this 21st century, there's still such a major stigma. In the 70s, when I was in the field, we had a separate building. The main hospital didn't want to have anything to do with the alcoholics and the addicts. I got my feet wet on the alcohol detox unit. Then I got transferred to the alcohol. We had a medical surgical unit that dealt only with alcoholics, drug addicts, and psychiatric patients. I had proposed to them that they reinstitute this during COVID because COVID was, for the addicted patient, it was the worst time.
Yeah.
They would send them out on the street still in withdrawal.
Oh, geez.
And a lot of
Yes.
people died. A lot of people with alcohol and drug problems have died during the COVID pandemic.
I would like to see those stats because
Yeah.
right now in my retirement, I have a few irons on the pot, on the stove or whatever. What I would like to do is to re-enter into a private practice. My goal would be to work with nurses and addiction.
Yeah.
That's another one of my passions. I
Well-
have, yes.
I'm sorry, Jacqueline, I want to get time for Kelly too, and I.
Oh, okay, sorry.
Sorry, no, don't apologize. I wanted to say, I thought I heard you say you're a CARN, a certified addictions registered nurse.
Yes, I missed I attended the October conference, but I missed the recertification. So I've been working on, that's why I really want to attend as many webinars as possible, because I did get an email asking me if I was still interested, but I haven't been able to follow up.
I hope you do follow up. You're a nurse practitioner, so are you a CARN AP? or-
No, I'm not a nurse practitioner.
Okay.
I never pursued that. My master's is in healthcare systems management.
Okay, but you were a CARN, and
Yes,
you brought up the importance of continuing education. So, Robert, I don't know whether, and because I'm not the main facilitator of Journal Club, I can't remember if we offer CEUs for people who attended Journal Club. It's possible we do, or credit hours. But I wanted to bring everybody's attention to the last page of Dr. Golden's article.
okay.
It's got where you can get contact hours for reading the article and then taking the test and mailing it to the publisher. And if you do that by June 2nd, 2023 for this article, you can
Great.
get CEUs,
Contact
contact hours that you can use for your certification. And Jacqueline, I hope that you're a member of INSA. If you're not, I hope that you will become a member of INSA.
I am.
Great, thank you. I'm sorry I haven't met you at some of the conferences, or maybe we talked and I forgot, but I'm so glad you're here today.
Thank you.
Looked at our NC USA yet? Just throwing that in there.
We're having meetings about setting up INSA USA. And so there's going to be, there's an INSA global board, and now there's going to be an INSA chapter for the United States, just like there's a chapter for Brazil and Portugal and United King or England and Ireland and
No,
Yeah,
you're not.
a good part of the last year for presidency from
Okay.
2019 to 2020.
Yours are probably, yes.
John, you need to mute. Was helping set up the infrastructure for the new the reorganization that we had, the restructuring of INSA. Now, Kelly Kokos, and I realize we only have 2 minutes left. Kelly Kokos says she didn't have a mic or a camera, but she's the Ontario representative for the Canadian chapter of INSA. Thank you for coming, Kelly, and I'm glad that you have been enjoying these Journal Club meetings. For a while, I was teaching on this day at this time and couldn't come to all the Journal Club meetings, but I hope that everybody that came today will come back to future Journal Clubs. And Kelly says she's an NP and works at 3 rapid access addiction medicine clinics in Southwestern Ontario. So we really hope that all of you that came today, Ola Remy, my little sister, who's, that I precepted for 5 or 6 semesters while she did her DNP project. Her specialty area, Remy, is in diabetes education and diabetes prevention, but she realized 2 things during her time with me, and we still teach together now, that alcohol and drug use is a risk factor for diabetes as well as smoking, and they make diabetes have worse outcomes. but also she's the liaison between the United States, between INSA members in the United States, and she's the liaison with the INSA Nigeria chapter. She formed the Nigerian chapter of INSA, and she's always looking to do training. And I know the nurses in Nigeria, this is a shout out for you, Nigerian nurses, really enjoy the journal club. And so I really do want to thank, it's 1 o'clock on the nose. I want to thank Dr. Golden for agreeing to be here today to talk about her study. And I really hope that the nurses at the Nebraska hospital start doing this even after you're gone, from doing research with them, that it's a sustainable practice change. And I'd like to see all of you back at the next journal club meeting, which I think will be this week on this day at this time next month. Robert, are we going to have one in August?
They're quarterly.
Oh, they're only quarterly. Okay. Well, we need to do them more often. And now we have, after we developed the INSA website for the e-learning portal for the October 2020 conference, at which almost 1,000 people, or maybe a little over 1,000 people attended, compared to our usual face-to-face conferences where we were lucky if we got 230 people to attend. We're now able to make learning opportunities available to more nurses all around the globe more often, and most often they're free. So keep an eye out on the INSA website for future education offerings and for future journal club meetings. And I hope to see all of you here next time, same place. Bring a friend. Thank you, Dr. Golden, for representing Nebraska so well with your project and your paper published in the Journal of Addictions Nursing. Thank you, Dr. Ann Mitchell, our editor-in-chief, for highlighting this article, and we'll see you all later. I put my email in the chat box. If anyone wants to email me, I can share the expert screening instruments and data collection sheets that I use, and then you'll have Dr. Golden's and mine, and we can start communicating more. You know, I don't want this just to be something where you come and sit. I want you to come participate and be involved. So I'll see you next time. Thank you for coming, and have a great summer.
Thank you guys so very much for coming. I enjoyed speaking with all of you.
Thank you.
Have a wonderful day.
You too. Bye-bye.
Bye.